So Michael, one of the interesting things about PRIMA is that they changed the dose. They personalized the dose. Tell us about that.
Yeah. So, the original observation really extended from NOVA, where there was not an insignificant amount of thrombocytopenia. We were involved in that trial, and there were patients whose platelet counts went down below 10K. A retrospective analysis of that study showed a lot of those patients could be identified because of body weight, low body weight, thin habitus, and low platelets, called weights and plates. And so when PRIMA was designed, as you know, this was then inserted into what we would call individualized dosing in that trial. And I think, like a lot of things, there's good news and bad news. I think the good news is that that approach worked. There was much lower incidence of thrombocytopenia, although I might add, when it was presented at ESMO, it was a little confusing because they had low platelets and thrombocytopenia, and I couldn't quite figure out what the overlap was. But that's been clarified since then, and I think it's about a thrombocytopenia drop from 38% to about 20, I believe, which is pretty darn good. And most of us are using, I use it if I see a patient like that. And it starts at 200 rather than 300. You always have the option of going up if you want. So there's been some interesting mumbling in the background that maybe 200 should have been the dose to begin with. But I think this is a perfectly reasonable compromise.
Yeah, one of the interesting things is, although the label for PRIMA, the prescribing information PRIMA, is this: if the baseline weight is less than 77 kilograms, or if the baseline platelet count, either one, is less than 150,000, that you should start at 200. But it was not applied to the NOVA or QUADRA data, although, Michael, as what you said, that's what we're going to do. And in the label, they do show that there was no difference because you just got to the right dose a cycle earlier. Patients sort of sort themselves out based on toxicity in the first cycle. But that I think is impactful. And at ASCO, we're not going to get into the specifics, but they even showed that the curves, that there was no difference in the efficacy with the personalized dose.
It doesn't, I'll just add, Brad, it doesn't mitigate the issue of getting weekly platelet counts when you put a patient on Niraparib.
Thank you. And we actually do that in my practice for all PARP inhibitors, just to keep it simple. And if the platelet count is less than 100, which means 99 or less, you should stop, okay, and sort of reassess.